So good afternoon, everybody, and thank you so much for joining us on this rainy afternoon here in Winston-Salem. I'm Goldie BYRD, and I'm director of the Angelou Center for Health Equity. We are just delighted that you are here and you're joining us today for this COVID-19 update. It certainly has wreaked havoc on all of us. What you need to know about testing, contact tracing, and vaccines. Again, I'm Goldie BYRD. I'm so delighted. Our panelists are really taking time today, such valuable time to share with us in such an authentic way. And we couldn't be more proud of their, humbled by their taking the time to do that. Today we have Dr. Allison Mathews, who many of you already know, who is the Associate Director of Integrating Special Populations here at the Angelou Center for Health Equity. And she has certainly been instrumental in bringing these outstanding panelists with us today. She will be addressing health equity and COVID-19 testing. She's been working very, very hard in that space in recent months. And then next we have Dr. Michelle Laws, who's the Assistant Director for Consumer Policy and Community Engagement for the North Carolina Division of Mental Health. She will be speaking about health equity, community engagement, and COVID-19 contact tracing from a state level perspective. So we're very excited about that. And then last but not least, we have Dr. John Sanders, who is Chief of Infectious Disease within the Division of Internal Medicine here at Wake Forest Baptist Health. And he will be joining us a little bit later in discussing the status of vaccines for COVID-19. Now, the format for today's session will have each panelist present for approximately 10 minutes. And then after all three panelists have spoken, the remainder of the session will be open for question and answer. We would ask you to please place your questions for the panelists in the chat box. Just check on the chat at the bottom of your screen, and so that the panelists in the chat will be able to address those questions. I'm excited to have Dr. Allison Holt, who will also be joining us and who will be moderating the questions this afternoon. I'm so excited again and delighted to have all of you here today. And we're looking forward to this presentation. It's a very important presentation. This time, we'll just give the floor to our first presenter, Dr. Allison C. Mathews.
All right, thank you, Dr. BYRD, for that introduction. I appreciate people who have been able to join today's call. So today I'm talking about health equity for COVID-19 and beyond, with a particular focus on thinking about how COVID-19 has impacted African American and Latinx community members. So just to give some background, I'm a sociologist by training, and my research particularly focuses on how do we better engage community members about research and increase access to healthcare. And research is one mechanism to do that by creating these prevention and treatment interventions that are directly beneficial to community members. The only way that we're able to do that is by involving community members in the process from the beginning, early on when we're designing research studies, and throughout the process when we're thinking about how do we recruit and engage and educate people about research. And so through that process, a lot of the work at the Angelou Center and also through the program that I direct at Integrating Special Populations, we do a lot of meeting with different community groups to get feedback on, what are some of the barriers and challenges around different health topics. So for coronavirus, we really have been meeting with community groups here in Winston-Salem, as well as trying to get feedback from colleagues across the state. We've been also in conversation with Dr. Michelle Laws and the Office of the Governor and Department of Health and Human Services. So a big part of this issue around coronavirus is, as we know, is access to testing. There have been an increase in overtime. We already know that there's been a huge increase in the amount of cases of coronavirus. But from this map, you can see that the distribution of kind of the impact of coronavirus is not even. Some of these counties, have fewer numbers of people with coronavirus, and then some of them have higher numbers. And so this map shows not only the number of people who have coronavirus, but the number in proportion to how many people actually live in the county. And so this red county in the bottom is a rural county that it may not necessarily have a high, quote unquote, number of cases, but relative to the population, it is a very high rate of coronavirus. And so we are in the Maya Angelou Center for Health Equity and across the state who are focused on and really dedicated to thinking about health equity are also trying to think about how this virus and this pandemic has a disproportionate effect on rural populations, African Americans, and Hispanic community members, Spanish-speaking populations, who oftentimes who don't have the luxury of being able to stay at home and shelter in place, oftentimes because they are frontline workers and don't have the resources to be able to work from home. So even in this red county actually is a location where there's factories that, agricultural factories, meat processing plants, where people have to travel into work and be there in person. And so this spread of the virus is also particularly impacting people who are vulnerable, who are exposed through work and cannot stay at home. The other issue is that, as we know, there's a very limited access to testing, to actual testing kits. And many people in the community have talked anecdotally and kind of told us stories about their difficulty accessing testing. It's blocked off. It's supposed to mimic the map of the United States. But if you can see in the bottom kind of third row, North Carolina is one of the states, one of the 36 states that are far below the target on how many, on reaching and being able to test people in the population. And a big part of, there's multiple reasons why that is happening. One is that the tests cost a lot of money. They cost between $99 to $125 per test. And then it costs a lot of money to process the test and get the lab results. There's also issues with not having testing sites in convenient locations. The New York Times and several articles have talked about the fact that many testing sites are concentrated in white communities and are not represented very well in Hispanic and Black communities. And so oftentimes Black and Hispanic people are required to travel to those other locations throughout the city. And oftentimes they don't have transportation or they have to take the bus. And when they get there, they may not present with a certain amount of symptoms that are required to get tested. And so then they get turned away. And so these are major issues that are really impacting this pandemic in a disproportionate way. I also wanted to highlight that here in North Carolina, we have increased the number of tests that happen daily. And you do kind of see a slightly lower trend of positive tests over time, which is great, but we still have a long way to go. Ideally, we would like to be under 5% of positive tests. And if you break that down by racial demographics, then you're going to see that, even though the average is 8% positive tests, there are going to be much higher positive tests in Hispanic communities and in African American communities. In Forsyth County in particular, over 50% of the positive tests are represented among Hispanic Latinx community members. And so there's a disproportionate kind of impact of this pandemic. And then this is just a map of Forsyth County and the testing locations. For people who are not familiar with Winston-Salem, the testing locations, if you see that the actual name, Winston-Salem, that's in there, to the right of that, these two dots, and then the one that's far over that looks like it's close to a lake or something, that's East Winston. That's the concentration of Black residents. And then if you look just north of that is a concentration of Black and Hispanic, and then just south of that is Black and Hispanic. So there's significantly less number of testing sites, fewer number of testing sites on the eastern side of Winston-Salem as compared to the western side of Winston-Salem, where there's predominantly white residents. And so this reflects a pattern. This is not unique to Winston-Salem. This reflects a pattern across cities, across the nation. And it's something that we really need to do better about, in being, especially because those populations are the hardest hit. Some of the feedback that we've gotten from community members about kind of their experiences getting tested and trying to find tests and you know, just that whole process has been that Black and Latinx folks can't stay at home. They you know, to stay safe and to protect themselves oftentimes because they have to go to work or, you know, and yet there's also this, you know, this legacy of mistrust, these structural barriers around transportation, about mistreatment once you get to a medical provider. These are exacerbated. These are made even more straining during the pandemic. And then, as many people are very familiar, racial violence and threats of deportation have also created added stress and barriers, and oftentimes prohibit people from even wanting to leave their house or to access healthcare because of fear of the way that they're going to be reported or treated throughout this process, and getting exposed to lack of safety. Oftentimes also people are, you know, realistically in a world where we don't have a pandemic, many people rely on their parents or their grandparents to help them take care of their kids, and or you're helping take care of your parents. Now, during this pandemic, that makes it much more difficult because you can't travel, you can't be around elderly people. They're at, you know, and the older adults, you know, don't know necessarily how to navigate using technology to communicate. And so those issues have also been strained. And then, you know, obviously household duties, we all know that women do more work in the household, but this has been even more strained, especially when even if a spouse is at home, women have reported that they have had to do more household duties on top of taking care of their children and on top of working from home. And then lack of access to supportive services. Services have closed down, or the schedules have changed and things are not as accessible as they were before, even though before the pandemic, they were also still hard to reach. Many people live in rural areas, and particularly in the rural areas in North Carolina, there is very limited access to internet and computers, and a limited knowledge of how to use the technology, even when they have access to that technology. There's been many reports of people who, you know, students who have received tablets and never actually logged in. And so it's not just an issue of having access to technology and resources, but also knowing how to use them, having social support to encourage them to use these things, and then knowing how to navigate those resources. Quickly, I'll go through. My Angelou Center is working quite hard to think about ways to reimagine, use this as an opportunity to reimagine equity, and to use this using a collective approach, working with community members, getting feedback, involving them in the process of designing programs and interventions and applying for grants so that we can address those barriers. And so I'm just going to quickly go over some of the projects that we're working on. We have the Triad Pastors Network, which includes 109 African American faith leaders across faiths. We have Christian, we have Muslim, we have non-denominational, right? So all of these kind of different faith communities working together to educate the community about coronavirus, about how to use technology, how to better engage, and also educating people about health, other health topics in general. And then we've also worked with about 45 congregational health ambassadors who were appointed from these churches to receive training on a monthly basis to learn more about how to better engage the congregations and the surrounding community about health. We've also partnered with the COVID-19 Community Research Partnership Study. And that one is focusing on increasing access to home testing kits for people so that they don't actually have to, so that we can test antibodies for coronavirus and see how coronavirus is tied to and disproportionately affects people with pre-existing health conditions. What is the interaction with pre-existing health conditions? How does that affect the body? How does it affect people in the community? How does it affect community spread? And so that study is underway. And then, so these are just examples of materials that we've helped create in partnership with community members getting feedback. And also part of that study has been to support minority-owned vendors. And so the man on the left is Marcus Hawley, who's the owner of Natty Neckwear. And he has, we hired him to create the mask for the study. That's not the mask we're using, but that's one of the masks that he has created. And then we're also working with a minority-owned vendor to print out all of the materials, the T-shirts, the flyers, and that kind of thing, and working with two other minority-owned vendors to create the hand sanitizer so that we can distribute that out to the community. And also we're partnering with the Wake Forest Baptist Mobile Health Clinic to increase access to primary care, educate people about coronavirus, increase their access to coronavirus testing in the community, and also working with Forsyth County Department of Public Health in those efforts. You can see Dr. Raina Rodriguez in the middle, and then we partnered with the Hispanic League as well. So that's just to give you some background. I do welcome questions on the issues around testing, around research, around any of those topics. Thank you for your time.
Thank you, Dr. Mathews, for all of your insights about looking at patterns of testing and site availability for our underrepresented populations. Next, we have Dr. Michelle Laws, and she's going to be talking about community engagement with regard to contact tracing for COVID-19. You can begin, Dr. Laws.
Thank you. Thanks. I just want to say it is a pleasure to be on this panel with a good friend and someone that I really admire work, and all of you, and certainly Allison and I have done some really good work together around HIV and AIDS, and just so thrilled that she is at the Dr. Maya Angelou Center. I will go ahead and get to it. I first want to greet you all and give greetings on behalf of Dr. Mandy Cohen, who is the Secretary for the Department of Health and Human Services, and all of our leadership team there, who is doing really, really hard work to try and slow the spread of COVID-19 in North Carolina. We are using multiple prongs and addressing this very highly aggressive and contagious and even deadly virus on many levels, on multiple levels. We're focusing particularly on what we call the 3 T's, testing, contact tracing, and trending. So making sure that we are leaning in and putting resources behind being able to address some of the issues that Dr. Mathews presented on in terms of getting testing sites stood up in areas where we know that there are populations that are most likely to be disproportionately or disparately impacted by the COVID-19. We're also tied to that doing work around making sure that we are building a workforce of contact tracers. And I'll talk a little bit more in detail about each of these and from an equity lens, and as we are looking at addressing this crisis among historically marginalized populations. And then, of course, the other T is trending, looking at what, the data are showing us. Again, our work, the work that I do as one of the co-leads for, for the historically marginalized populations work group, a lot of our work, all of our work centers on looking at ways that we can mitigate the effect of COVID-19, but also, address some of the structural and longstanding disparities that have existed within these and among these populations for a very, very long time. And so for us, we had to be very clear about which populations we are talking about and which populations we are developing strategies and policies around to address and to prevent the spread of COVID-19, and also address some of the impacts, especially for those who have tested positive and who are struggling with multiple chronic conditions. And so when we talk about HMPs from the state's perspective, we're talking specifically about African Americans or Black, Latinx or Hispanics, American Indians, immigrants, and refugees. What this virus has done, it has unveiled or highlighted, illuminated longstanding disparities, yes, but it's also shown us some hidden communities, right? So for example, when we think about the refugee population, in looking at or responding to an outbreak at a particular facility, it was discovered that there was a large population of Swahili-speaking persons who spoke Swahili from Africa, who were also working side by side with Spanish-speaking immigrants or refugees and members of the Spanish-speaking populations in North Carolina. So again, it didn't create these disparities. It simply highlighted and illuminated some of these hidden communities and populations. Dr. Mathews has already shown these data, but basically as of yesterday, I pulled this. This data showed that in terms of the confirmed cases in North Carolina, there have been 105, and there are more, I'm sure, if we pull today's data, 105,000 lab confirmed cases. What we do know is that people are, especially those who are walking around asymptomatic, we know that there are many, many, many more cases potentially that we are not and have not identified and confirmed. We've completed over 1.4 million tests, and I'll talk about specifically the strategies that we have employed to address the disparities among historically marginalized populations. And then we also know the reality is that not everyone recovers quickly, and other people, who may not have any health complications at all do fine, but we have a segment of our population who don't do fine and don't do well, and we'll unpack that a bit. And some of those end up in the hospital. So currently we've got 1,137 persons reported in our hospital for COVID as a result of COVID and COVID-related health complications. So why is it important, and why was it important for North Carolina, for specifically Secretary Cohen, to stand up an entire work group across that includes people internally and externally across different disciplines to specifically zero in on COVID's impact on historically marginalized populations. I'm sure I am preaching to the choir in terms of the participants and the viewers of this discussion. But what we do know is, again, COVID did not create health disparities, but what we do know is that that it has shined a bright light on disparities that have existed for a long time. So these numbers are probably not surprising to many of us. African Americans make up 21% of North Carolina's population. However, using data from yesterday's data draw, we make up 24% of confirmed cases. Now that is good because for several months into the pandemic, starting in March, we were above 30% of those of the cases, compared to Hispanics, members of our population who make up 43% of the confirmed cases. What's important for us to look at is to compare the cases and then also the deaths and then also hospitalizations and also, you know, other impacts and effects that COVID creates. And so I just simply pooled the death data and the cases. When you look at the deaths, who's actually dying from this disease, this virus, as it relates to historically marginalized populations, you will see, although the Hispanic population makes up 43% of the confirmed cases, they make up 11% of the deaths, and they're about 9% of North Carolina's population. So this is still disproportionately higher than their representation in the among the general population. When you look at the percentages of deaths comparing African Americans, however, to their cases, although again, we make up 24% of the confirmed cases, we represent 33% of the deaths. And so focusing in on historically marginalized populations is not only makes good policy sense, but in terms of where we need to direct resources and in terms of really looking at this from an equity lens, it makes sense on an equity level also. I would use the term justice or just, but it's an equitable use of our resources as well as our focus. And some may say it's the right thing to do, right? You put your resources in, target and tailor your resources to those that are being hardest hit or impacted at the greatest. And what we do know, we know that COVID-19 again is affecting all communities. However, it's affecting communities, historically marginalized populations, disproportionately. We know that these health disparities are historic, systemic, as well as persistent. They go on, and then there's this compounding effect also. So not only, you know, is it one disparity, COVID disparities that we're looking at, we're also looking at the effects and the correlations to other things such as economic devastation among these populations as well. Looking at the ability for people to recover and to social isolate and the disparities in that, who can do that and who can't. And Dr. Mathews talked a little bit about that as well. We can even see it who's in the returns to school. I was listening to the news the other day and heard a report about parents looking at private schools settings to send their children. Well, who's able to afford private schools? Those who are on the higher end of the socioeconomic strata. We also know, and this is a common response in terms of why, in particularly African American populations and Hispanic and Latinx populations are disparately impacted by COVID and suffer more serious illnesses as once infected or once they contract COVID. We know about the pre-existing health disparities, and so we know about the high rates of diabetes. We know about the high rates of hypertension and so forth. And so when you add on top of that a virus and infection like the one that we have, here that we're dealing with COVID, then of course you're going to see an exacerbated effect in terms of across illnesses and diseases. And people of color are overrepresented, as Dr. Mathews stated, and as frontline, low-wage workers, essential workers. They're less likely to be able to take time off from work to recover, because many of them may not have sick leave. If they do have sick leave, they probably exhausted their sick leave coming into this pandemic or shortly thereafter. Many are represented among secondary employment, which also increases the risk of exposure. The more you are out in public places, the more you're out interacting with the public, increases your chances of contracting COVID-19, especially if you're not practicing the preventive measures. And then again, the usual culprits, right? The usual risk factors. So the social determinants and drivers that also play a role. Not being able to pay for a test, but I'll talk about that and our response to that, or not being able to pay for adequate health care. And so all of these factors are combining, there's an alchemy of risk that are placing historically marginalized populations at a great risk for COVID, not just contraction, but the worsening of the effect of COVID. And we know that both health outcomes and services and the way we respond require an equity lens to address. And this is just a graph that I wanted to drop in, looking at, who's able, when we talk about workers that are teleworking, who's more likely to work from home. And so this was published in the Economic Policy Institute, but it's since then it's been reported on multiple times, and this came out in June. So we know that when you look at the share of workers who can telework by race and ethnicities, African Americans or Blacks are less likely than Asians and whites to be able to do so, and Hispanic and Latinx or Latino are also less likely, 19.7% and 16.2% respectively. When you add on top of that other factors such as congregate housing, limited resources and supports, some people can go home to family houses and dwellings. Auntie may have 2 spare bedrooms, and so if you're told to quarantine or social isolate and your house is full, you've got you took in your nephew, you took in your sister's child or your cousins or whatever, and you got your children there, and it's social isolating is just not practical, or quarantining in your house is just not practical, but you may have a relative that has 2 extra spare bedrooms. The chances of that being an option, or those kinds of options being available to historically marginalized populations, is much lower than it is for whites, and particularly when we look across the state. I know there are enclaves of poverty, impoverished Caucasians and whites, just like there are other race and ethnic groups. But when you look at it in the collective, when you look at it aggregately, the chances of these resources that allows people to be able to recover from COVID once impacted are just not available. And it makes it harder for people to adhere to the public health guidelines and policies that we are recommending unless we're able to provide supports. And I am thankful that under the leadership of Dr. Cohen, there is a group, a team that is working on quarantine and isolation supports to be able to better help facilitate a positive response to some of the guidances. So on the testing strategies from an equity lens, from a health disparities, from looking at historically marginalized populations, we did something that was just really, I think, a game changer in getting testing sites out into places, or testing, making it available to historically marginalized populations and those that are highest impacted or vulnerable populations. And it's called our CHAMP initiative. You may have seen the press conference, press briefing when it was announced, but CHAMP is an acronym for Community Testing in High Priority and Marginalized Populations. And it's based on 4 cornerstones, really. One, the recognition that core public health infrastructure needs additional resources to meet the growing pandemic testing needs across the state. So it couldn't just be the local health departments standing up testing or making tests available. There needed to be additional resources and partners to address one of the barriers or one of the issues that Dr. Mathews pointed out, and that is, testing sites not being in locations where there was a clear need for them as it relates to meeting the needs of historically marginalized populations. And so vendors were brought on board, more testing sites. We looked at 100 zip codes starting out. We're now like in the 3rd phase of the CHAMP initiative, but we started out looking at 100 zip codes and saying, okay, where are we seeing the greatest need in terms of needing to go and stand up and provide testing? And from that, we through resources behind partners, as well as through 2 primary contractors that came on, and others have been added since then. We also understood that lengthening turnaround time for test results, driving the need for new sources of tests to get results rapidly to people. There was a lag, and still is somewhat of a lag, but from the time people get tested to the time they find out the results, right? And so in the meantime, what are you going to do if you're a worker that doesn't have extra cash on hand or savings on hand? You're going to go to work until you hear whether or not, or you're interacting and you don't know in public, and you don't know. And so there are 4 cornerstones, and the other one deals with just, understanding and recognizing that COVID health disparities are untenable and without the adequate resources and supports. And that is an iterative process. It's not a one and done. That we need to. There are other communities. There are other zip codes that need to be added, and that's what CHAMP. It's flexible. It's allowing us to follow the trends, as I mentioned, is one of the 3 T's. The other initiative is Operation 9, which is similar, but it's focusing really on 9 counties where we knew we needed to do rapid testing and tracing, and for different reasons. One, they were showing the highest number or rates of COVID cases. And so again, similar thinking around CHAMP, different. CHAMP focuses on testing, which you can find out about where those community testing sites are by going to our website and clicking on our information hub, and or find my testing place, or find a testing place, and there's a list of community testing sites that are listed there and made available to the public. But for Operation 9, similar but more expanded focus, working with local health departments to implement and to make sure that there are resources available to provide contact tracers within 24 hours of a positive test, so to deal with some of the issues that we saw that we were dealing with in terms of not just the testing lag, results lag, but also getting tracers out, finding as quickly as possible who may have been exposed. So Operation 9 and the CHAMP initiative. And these are just some data on the contact tracers. About 19%, about 111, 19% of the contact tracers are African American. About 35 are Hispanic and Latino. And then if you go down, we're also focusing not just on race and ethnicity, but language. And we have 54% that are bilingual. And so moving through this, we know that there are challenges with these strategies. One, again, because of the multi-factorial, way in which health disparities emerge and are created. There are multiple factors, right? There are also challenges with our contact tracing, and some of those you know, and I'm going to just speed through that. Community trust and so forth. We are doing similar work that Dr. Mathews identified in terms of reaching out and working with communities and engaging communities and community stakeholders. There are multiple teams that are working on that. The Historically Marginalized Population Work Group, the Office of Minority Health, and the Governor's Public Engagement. Using different strategies. I want to say one quick thing about the implications and considerations of COVID vaccine before I end. One is there is no vaccine today, but it is important as we approach this, as Pfizer and others that are working, pharmaceutical companies that are working on developing a vaccine, it is extremely important for us to make sure that we've got African Americans and HMPs at the table. We got to understand the key barriers and considerations that may prevent African Americans and HMPs, other HMPs, from participating in the development of a vaccine, i.e. clinical trials. Those same issues that existed in terms of the lack of involvement of African Americans in clinical trials in the beginning still exist, and we got to work through some of those. Mistrust, there's some, the FBI just sent out a warning about potential fraud and antibody testing for COVID-19, different schemes and scams. Our communities, these communities have been impacted the most, or the greatest in many ways, by schemes and scams throughout the ages, right? And then structural inequities are in the cost, access once a vaccine is available, and so forth. That is where I will leave it. I'll leave it with the 3 W's. Wear, wait, and wash remains the best way that we can get ahead of this this pandemic. And then these are just some resources. But thank you for your time, and I apologize if I went over.
Thank you, Dr. Laws. We really appreciate hearing about those 3 T's, the testing, tracing, and trending. You really imparted a lot of great information to us. Thank you so much. So next we have Dr. John Sanders, and he's going to talk to us more about the status of vaccines.
Thank you very much. And I do not have a list of slides here for vaccines. There are a number of them coming out, and I am happy to discuss them and take some questions about them. But I don't have a slide deck available for the variety of vaccines that are out now. There are over 120 COVID vaccines currently in testing, according to CDC and the WHO. Most of those are in preclinical testing. That means that they're in laboratories or in animal studies. But if you look worldwide, more than a dozen of them have moved into human trials now. And there are several that are already in making rapid progress through trials here in the United States or in Europe and other countries. The 2 that are getting the most publicity right now are both very interesting vaccines and have already demonstrated some very promising results. One is called the Moderna vaccine. Moderna is a small company in Massachusetts, and they have been working with NIH for years to develop a vaccine that uses a little piece of messenger RNA, some genetic material, to teach our cells or to tell our cells to make proteins that look like whatever germ we're trying to make a vaccine to. And the great plan with this, they had been saying for years as they developed this, is that this would be a very fast vaccine to produce in the event that a new influenza or a new coronavirus emerged in the world and we had to have a vaccine fast. Well, this has proven their point. A new virus emerged, and the Chinese released the genetic sequence of SARS-CoV-2, the virus that causes COVID. They released that, and 2 days later, Moderna had produced a vaccine ready to start to move into animal studies, mice studies, that sort of thing, and into production. And so in a shockingly fast amount of time, they produced a vaccine that first went through animal studies and looked pretty effective, and then has already gone through what's called a phase 1 study, which is the early safety and immunogenicity. Do people tolerate it? And do they make antibodies? Do they make a good immune response? And so they very rapidly got into a phase 1 study, tested it in 40 people, which is not very many. And in those 40 people, everybody tolerated it okay. But when I say they tolerated it okay, nobody had severe side effects. People had mild flu symptoms, a little bit of tender arm. It was a reactogenic vaccine. People responded. And they made antibodies, and they made antibodies at a good level. And this sort of vaccine is supposed to be good at having them make other type of immune response as well. But so far, NIH and the company haven't released as much data on that other immune response yet. So we're hopeful that that is also true. And that they have now moved into larger phase 3 studies that will be testing whether or not this is effective. And those studies are scheduled to start enrolling at various places in the nation as early as next week. So there is a large number of sites, 92 sites nationally, in which people can go and enroll and get the vaccine. Those sites can't advertise themselves until each site has gotten ethical review board approval to send out messages and put up posters and say, you could volunteer here if you want to be one of the first 30,000 people to receive the vaccine. So it would be, all I can say is that Wake Forest is waiting for ethical review before I can say that if you wanted to volunteer at Wake Forest, that we would be more than happy to see that happen. There are several sites across North Carolina that are in that process that will be taking volunteers, and the Moderna vaccine is coming out first in those trials. Again, next week, the week after, I think you're going to see a number of sites in North Carolina sending out messages that you're welcome to come volunteer for the study here. Shortly after that, we're going to see the second vaccine roll through from a company called AstraZeneca. And this vaccine was made by Oxford University in England, along with AstraZeneca. And it is an interesting design too. They took a virus that normally runs in chimpanzees. So it doesn't normally infect humans. And they've done a little bit of modification of this virus to make sure that it should not make a human sick with this virus, that it should not replicate and cause anybody to be sick. And they've genetically tweaked it so that that virus looks a little bit like, looks enough like COVID, looks enough like SARS-CoV-2 to generate an immune response. And they did a good phase 1 study of that vaccine and got great results, arguably even better than the Moderna results, mainly because we've heard more about it. They've given us more information. They just released that information in the last week. And you probably saw on the news a lot of excitement about this vaccine because it generated really good levels of antibodies and it generated really good, they call it T cell response, which is the other part of our immune system to fight viruses directly. And so there's a lot of optimism that this vaccine may be beneficial. Now there are a number of others that are coming. Oh, I'm sorry, I should have finished that thought. It is already entered into phase 3 studies and they're enrolling volunteers in England and in Brazil. And soon they'll start getting sites to enroll in the United States. So we expect to see people in the US getting to volunteer for that study as well. And then there are similar vaccines coming from Johnson & Johnson, which is really the Janssen company, from Sanofi Pasteur, from GlaxoSmithKline, there are a number of them that are moving through their phase 1 studies or into their phase 1 studies now, with plans to enter into those phase 3 studies between now and Christmas. So I expect that we're going to see pretty rapid movement of getting volunteers into these studies around the nation, and then to see what to see how well they work. And there is, of course, a lot of emphasis on trying to make sure that there is really good representation across all the demographics for these studies. And when I say all demographics, I'm talking about age. Often in vaccine studies, they really limit the age of who can volunteer because, quite frankly, speaking to somebody over the magic age, over the age of 50, we just don't respond as well to vaccines as we do under the age of 50. So when a company is normally bringing out a vaccine, they limit it to people between the ages of 18 and 50 because they really want to see if the vaccine works in the host that is going to generate an immune response the quickest. But in these vaccine trials, there is no age limit. So I see that I've got a question asking that, and there's no age limit on for adults. They're not enrolling pediatric volunteers yet, but for adults, they're taking any age to do the trials. And surprisingly to me, they are very open to people with lots of other health problems. Often in these studies, they don't want to take people who have immune system problems or other immunosuppression that might cause the vaccine not to work. But in this case, there are a few limits. There are a few medicines that people are on that might suppress their immune system that would keep people from being enrolled. But for the most part, it is large open enrollment. And there is, again, the local sites are not allowed to advertise and do outreach until we have ethical review board approval. It's called IRB approval. But there is a big push from the NIH and the FDA and the companies that are pushing these out to make sure that all the sites are really trying to reach out into the community as soon as it's ethically allowed to try to enroll the broad demographics of race and gender and age I've already spoken about. And so I expect we're going to see more and more of that. And there is a website just in general, and I will post it on the chat here in just a second, that nationally, the University of Washington has been tasked with trying to create a website so that if you are interested and want to be considered for one of these vaccine trials, but you're not sure which one, or you're not sure which site to go to, you can go to this website. I'll post it here in just a second, and go ahead and enroll on that website as a potential volunteer. And part of the reason that the University of Washington, in cooperation with the National Institutes of Health, has done this is because they want to develop a large national registry so that they can reach out and make sure that across the nation, we've got good representation, including in the African-American community, the Latinx community, so that that people can volunteer through that registry, and that they can make a specific outreach to them.
So explain why Moderna lost its challenge to Arbutus patent on vaccine technology. If AstraZeneca is ahead of Pfizer, why did the federal government pay $1.95 billion yesterday to Pfizer? I don't know if you know the answers to those questions.
Well, these are sophisticated, difficult questions that I think may be above me. I'm not sure why it lost it. I'm not sure why Moderna lost its challenge on that patent. I would say that there are an enormous number of groups working on similar vaccine technologies. I am working with a group that has a more old-fashioned but similar approach that we're pushing through Wake Forest right now in the preclinical arm. We're still in the animal phase of it, but it's a very similar approach. We just weren't as fast as Moderna and NIH in getting it through. So I suspect that there are a number of different groups who have tried to claim patents and intellectual property on very, very similar technologies, and that I will let them work that out in the court, as long as it works as a vaccine.
Okay, and what are the risks to volunteers who volunteer in the studies, and how are the volunteers protected?
So there are always a number of risks when we talk about any new medicine or any new vaccine, because quite frankly, we don't know all the potential side effects. I would say the ones that we know so far, based on the phase 1 studies that have been released, is one risk is your arm is likely to hurt, especially with the Moderna vaccine. At the higher dose, these people had a pretty good reaction in their arm, and a number of them had a flu-like illness, low-grade fever, and they felt bad for a day or so. So I think that not all of them had that, but I think that there is a risk of that happening right away. The next risk is that we get those symptoms because we're generating an immune response. Now, we don't know how protective that immune response is. That's why we're going to be doing these vaccine trials. We hope that they're protective and keep us from getting infected. There are examples. They're very rare, but there are examples of immune responses that not only don't protect us, but might even enhance an infection if we got it later. So is it possible that somebody could get the vaccine, still get infected, and actually be sicker than if they had not had the vaccine? It is possible. That is a risk. I consider it a very small risk, but I think it would, certainly anybody that I enroll into one of these trials, I'm going to make it clear that that's a possibility. There is also a possibility that they will have an immune response and an inflammatory reaction that doesn't necessarily make it worse for them if they get infected with the vaccine, but that they may have other reactions to it, including, joint pains or, swollen fingers or swollen toes, that sort of inflammatory reaction. And Dr. Fauci has mentioned this a couple of times recently in his press conferences, that normally you go from a very small phase 1 safety study that is more on the order of 10 to 20 people, not 40 people. And then you go from phase 1 to phase 2, where you might do 30 to 100 people and really learn more about the immune response and get more safety data. And then you start to talk in the thousands of people for an efficacy study. And because of the urgency of COVID, we have moved very quickly from a large phase 1 study that's kind of a blended phase 1, phase 2, rapidly through phase 2 studies into a very big phase 3 study. And that brings with it some risks to the volunteers because we don't have as much safety data as we normally would. And Dr. Fauci has been very clear that we're going to have to watch our volunteers very closely, work with our volunteers and watch them very closely to see, are there side effects that we're not anticipating? And I think anybody who volunteers for these needs to know that, and that we need to applaud them for being willing to step up and take a risk to help the rest of us to see if this is a safe, effective vaccine. I think that the other part of that was, how are volunteers protected? Generally speaking, if somebody has a specific reaction to a vaccine or a medicine in a trial, there is some insurance that goes along with the trial. So in these cases, the government has funded these companies to provide a little bit of insurance. It is not insurance to take care of every problem, everything. It is insurance that is specifically to address those problems That's standard for every clinical trial. In terms of specific protection, it's less about specific overall protection and more about working together to monitor, looking for these things.
And there was another question, Dr. Sanders, about given your comment about the efficacy responsiveness of individuals over 50 to vaccines who are at greatest risk for COVID-19 complications, how effective a vaccine may be in this population? Is it a chance that it might not work as well for people over 50?
I think that is a wonderful question. I think that these are sophisticated questions. I don't think that there has been this level of sophistication being discussed on the news and in the press conferences that are often out there. So I really appreciate this question, especially because we seem to often be falling into this discussion of, oh, a vaccine's going to come protect us all. Very few of our vaccines protect all of us all the time. It's a matter of enough of us getting the vaccine to keep the spread down. And in almost all of our vaccines, there are certain populations that don't respond as well as a group. And one of those groups is the older we get, the less well we respond. 50 is a magic number, but it gets, not some of us at age 51 are going to do great in responding to a vaccine. Some of us at 61 or 71 are going to do great, but fewer and fewer of us respond after we cross the age of 50. And I think that means that we cannot count on one of these vaccines being the magic answer for protecting our elderly friends and relatives, for our nursing home population, for our older at-risk population. There are a number of other things being looked at to protect them. We can talk some about those. But what we really are going to want to do is, if these vaccines are effective, it becomes everybody's civic duty to go out and get it so that the people who do respond are protected, so that they don't get infected and pass it on to their mother or their aunt or the person they're visiting in the nursing home.
Thank you, Dr. Sanders. This question is more generally for all of you. What are your institutions doing to ensure that Black community members have access to the resources they need during COVID-19? And also, what are Wake Forest Baptist Health and Novant partnering to increase testing locations in underserved areas?
The biggest things that we're doing are we have weekly calls on Thursdays at 1 p.m. People are more than welcome to join those, and you can email me. I'll put my email in the chat so that I can add you to those calls. Those calls give the community members an opportunity to give feedback on research studies. In particular, right now we're focusing on the COVID-19 community research partnership study that is focused on antibody testing. And so that's one thing, is the community calls. Then we are also partnering with Forsyth County Department of Public Health, the Hispanic League. We work with Hustle Winston-Salem, the Forsyth Tech Small Business Center, and community-based organizations throughout the city to educate them, kind of send information out about coronavirus. And then we send out resources. We try to send out resources through an email listserv. So again, email me and I can add you to the email listserv so that you can get access to that information. We try to send it out at least once a week. In addition to that, we are working with the Triad Pastors Network, which is 109. Also includes Love Out Loud, Winston-Salem, and the 20. I know we have a representative who's watching today, who's from the 20. We also work with the Triad Pastors Network is 109 pastors, African-American pastors in their churches, to educate them about coronavirus. We host bi-weekly teleconference calls with the faith leaders to address concerns that are directly affecting churches and their faith leaders in the congregations. We talk about pastoral burnout in being kind of mental and providing mental health support for their congregations. We talk about financial wellness. We talk about how to properly clean their facilities and plan for reopening. And so really trying to address the topics that are specific to congregations. And then also we've done some training with congregational health ambassadors whom they've appointed to get feedback and also train them on how to educate the public about health topics. In addition, we're partnering with UNC and Duke and other entities to think more comprehensively about how to create technology tools, apps, create interventions, outreach, working with the contact tracers to get information out about coronavirus, how to protect yourself, and also thinking about, yes, the stay-at-home message is important and it helps, but if that doesn't speak to the lived experiences of the most vulnerable populations, then we also have to think about messages and interventions that can also keep them protected. So we're in the process of just getting as much feedback as we can from community members so that we can think through and design messages and interventions that reflect those experiences.
And I added my email. We're doing quite a bit, but for the sake of time, if we have a work group that has 5 strategy teams that's doing a lot of work around communications and engagement, testing, access to testing, contact tracing, essential workers, focusing on that, and minority providers and procurement opportunities and processes. And then there's a third one, I can't remember it, but my email address is also in the chat. Please, if you're interested in joining one of those strategy teams, learning more about what we're doing, it would take quite a bit, but really, listening sessions, town halls, messaging, participating and conducting and leading research, developing messaging campaigns with the communities that are impacted at the table, helping to design the messages and so forth. It's quite a lot, and certainly a lot more that we need to be doing. So would love your feedback and love your support as well. So my email is there just because of time.
And then to address the specific question about Wake Forest and Novant partnering together, I don't think I'm high enough up on the totem pole to specifically talk about partnerships, but I will say there has been a lot of coordination. So I'm not sure, I'm not sure exactly what agreements have been signed, but I know that the head of Wake Forest's ambulatory program and testing program has met regularly with the Novant group. Our 2 leadership activities are meeting regularly to discuss who is placing resources where, and they've gone so far as to laying out maps and saying, here is the density of this population. Do we have enough testing sites and testing centers here in this area? Novant has one, Wake Forest. So I would say that that's great cooperation. I'm just a little cowardly about calling things partnerships without knowing what I'm legally allowed to say.
Thank you, Dr. Sanders, for addressing that to the extent that you're aware. The next question is primarily for Dr. Laws. How does the fact that testing takes 4 to 5 days minimum to come back impact our ability to effectively contact trace? Are there any rapid testing sites in Forsyth County?
Excellent question. One that creates a lot of headaches. at the Department of Health and Human Services. I can tell you that. You know, we know we've got to, and we're doing better. Some of the turnaround time from test to lab to results out to the tested individual is shrinking or decreasing, but still, you know, we still know that we've got a lot of work to do, and it doesn't affect it, right? Like I said in my presentation, you know, you get tested, you know, you still have to go to work. You didn't get tested through an employer. Say you work at a construction site or, you know, a particular site where they're not offering testing on site. You go and you stop at one of these community testing sites. I put the link, by the way, to free testing sites in the chat that are spread out across now more than the 100 counties. And you're interacting and engaging. You're absolutely right with people and not knowing if you are exposing them to the virus. So it has a tremendous effect. And it is one that we're trying to work through. The turnaround for hospital testings is turnaround time is a lot faster, and it just depends on the actual lab or provider that's being used. But that's an excellent question, and it is an issue that impacts.
There is a testing event that will be hosted on, I want to say on August 8th, and I can send that information out to all the attendees. And that's in collaboration with Old North State Medical Society. They actually have the ability to return test results in 48 hours. They're working with a private lab. And so there are opportunities for more rapid turnaround results. It just depends on who you go to, and you know, different organizations are working with different labs, and the state labs, you know, are backlogged. So everybody has different labs, and so it just depends on who you're working with. Some are able to get the results back faster than others because there's less of a burden.
That's correct. And Dr. Charlene Green with Old North State actually is on our HMP and leads our test surge work group. And Dr. Mathews is exactly right. Again, it depends on the vendor, it depends on the lab. There are factors that affect that. But the longer the delay, which I think was at the heart of that question, you're absolutely right. It does, you know, handicap us in terms of being able to contact trace effectively and stop the spread or reduce the spread. You're absolutely right. And I think that if you'll check that list of the community ones, I think the Old North State one might be on there. I'm not sure.
Thank you, Dr. Laws. We'll do a few more questions. This one is directed for Dr. Sanders. What are the long-term impacts on the human body for someone who tests positive for COVID-19? What do we know now?
Again, a great question, very, very sophisticated. And the short answer is we don't know much now. I mean, this is an infection we've only known about for 6 months or so. So it's not that's not long enough for us to really feel confident that we have adequately described the possible problems resulting from being infected. There are a number of things that we've already seen hints about, that people who get infected, we can see radiologic changes on CT scan in their lungs, even if they only had mild or moderate symptoms. Radiology reports are saying that they are able to detect changes on especially CT scans. Now, how significant those will be in terms of life, we don't know. But they are seeing more prominent changes than we usually see with a typical viral pneumonia or a typical process, especially when people are relatively mild. We're also quite concerned about the inflammatory response that develops after one of these infections that results in clotting cascade, a development of blood clots. Sometimes they can be fairly big blood clots, but often they're really tiny micro clots. a number of autopsy reports in patients who've died from COVID have come out showing that a big problem for the people who succumbed, who had fatal COVID, in a lot of them, were that they had lots of these little blood clots all through their lungs, through their kidneys, through other places. And that makes us quite worried about what might result for people with chronic kidney disease, with people with high blood pressure, with heart disease, who could, who might do fine through a mild infection and not even realize that they've had more of these little clots causing more damage to the organs that they're having problems with. And that may speed a process of heart disease or kidney disease. That may cause a complication. We've not seen these yet, but people are quite worried about, could we see more strokes or more heart attacks a month or 3 months or even 6 months after somebody had an infection? Now, so I don't mean to imply that happens. I mean to imply that we're concerned that could happen, which is why a number of studies are taking place excuse me. I've talked too much today. A number of studies have been set up to try to monitor people, to try to find out, are there these problems? The study that Dr. Mathews was talking about earlier is one of the largest in the nation, where we're trying to get people to enroll with us, that we will check their symptoms and check their antibodies. But a major part of what we're doing is trying to find out if somebody gets a mild infection, just a moderate infection, they don't have to be hospitalized, they don't have any problems, but we want them to stay in the study and keep tracking with us so that we can watch their health record and see, do they have any problems, so that hopefully we can identify these risk factors, these outcomes and complications that might arise, and be able to start making appropriate intervention sooner.
Thank you, Dr. Sanders. Sounds like there's a lot more we need to know. Dr. Mathews, how can community members get involved in helping shape how healthcare and research is done?
Thanks for that wonderful question. I am very passionate about this, and I think it's important for community members to recognize the power that we have. I know I'm a researcher, but I'm also a community member, and community members have a lot of power in how research is done. Some of the ways that you can get involved are by joining some of these council meetings and providing feedback. You can join the town halls, and give feedback that way. I would also, send emails directly to, I hate to say this, Dr. Sanders, send emails directly to the PIs. But, I think that investigators care about how the research we're doing impacts the community. And if they hear directly from you, I think that does inform how we design and implement these studies. Also, in addition, I would encourage people to, my Angelou Center for Health Equity is one of many centers for health equity across the country. They have one almost at almost every university, I would hope. I don't know that for a fact, but I'm pretty sure they do. And those centers are specifically there to help facilitate community-based input into research. So we have community advisory boards. I would encourage you all to join those. Those community advisory boards allow you to provide feedback on specific protocols, to attend meetings. And from my background with HIV, we've had community members come with us to the National Institute of Health for meetings and provide feedback and speak on panels as representation of the community and the concerns, and kind of address barriers and access to care. And so, you know, those are ways. And then just also just try to be as informed as possible, educate. You know, I would visit the NIH website. I would visit Maya Angelou's website. I would visit, you know, the Department of Health and Human Services website so that you can learn more about the work that's happening. And send me an email and I'll make sure you stay informed. And I always welcome people who want to be more involved, because we need your help. We need volunteers, and we need people to get involved.
And I certainly don't mind getting those emails. It may be Dr. Mathews' fault, but I probably get 6 or 10 emails a day on the study that we are doing together. And we try to respond to all of them, and they certainly do help shape what we think we're doing and what we should be doing.
Thank you. It's good encouragement for lots of community members to get involved in research and shaping that thought. Last question, and this one is going to be for Dr. Laws. Community members have expressed concerns about getting COVID-19 testing because it would prevent them from being able to work and provide for their families. This is a concern particularly among community members who do not have access to childcare and cannot afford to take off work for quarantine. What resources are available to support people who test positive but cannot shelter in place or quarantine at home? What protections are in place to prevent people from losing their jobs if they test positive for COVID-19 and need to quarantine?
Excellent question. And again, it's something that the Secretary has been extremely concerned about. We have our quarantine and social isolation support team that's working on hopefully standing up and announcing soon some of the strategies and policies. We've been looking at things like the feasibility of, you know, funding to help with rent assistance. We've been looking at, so there are a lot of things. I don't want to get ahead of the strategy paper and team's work that's going to be coming out soon. But we are looking at that, and you can go to our website. There's supports for people. For example, we know some communities have converted old hotels into isolation spaces or quarantine spaces for people who can't isolate at home. And I know the main question is, what happens when you can't do it because you can't afford to do it? You've got to work, and that's been the main question that the state has been challenged with trying to answer. So we are working on looking at how we can offer aid and assistance to help people do that. We're looking at things, you know, like covering the provisions for childcare, or and one of the things that we did early on, and that came out of our under the leadership of Susan Perry Gale from our department, is we knew right away we needed to add additional money to the EBT to the food to allow people to get food with kids at home, no longer be eating at school, and so forth and so on. So we've done some things to mitigate the effects, the economic burden, and we're working with the governor's team to roll out more. There are executive orders and policies that are released on our website if you miss any of the briefings, and that's where I would say stay updated in terms of, you know, is there going to be rent assistance? We know the moratorium on evictions is lifting, and so, but remember, we got behind that quickly. The governor implemented or instituted an executive order, so we're still trying to respond as efficiently. It's not as, it's not as easy to stand some things up, especially when it comes to payment or reimbursements or subsidies and so forth, because some of the money's tied to federal dollars and strengths, and need congressional help as well.
Thank you, Dr. Laws. This has been a great session, and I thank Dr. Allison Mathews, Dr. Michelle Laws, and Dr. John Sanders for giving us this COVID-19 update on testing, contact tracing and vaccines. It has been an excellent session. This session has been recorded and will be shared with you via email after the session is completed. We thank all of you for being with us and sharing your knowledge. Have a great evening.